Hi, my name is Kelsey Ortman. I'm a nurse practitioner student through Maryville University. This is my volunteer patient for the day, Tammy. She's a 59-year-old female. We've already gone ahead and done our introductions. So I'm going to go ahead and start with the pulmonary assessment portion of this video. So I'll just go ahead and start by looking at a few anatomical landmarks. First, I can see her trachea is midline straight down to her sternum, her precordium. I can palpate her clavicles, her angle of Lewis, suprasternal notch. I can palpate her cervical spine back here. I feel C7 into T1. And then just go ahead and inspecting more. I can see that her lateral diameter is about half the size as her AP diameter, which is a normal finding. AP diameter should be 2 times the size of the lateral, showing no signs of barrel chest or anything like that. I also don't see, she's breathing comfortably, no shortness of breath, no appearance of respiratory distress or anything like that. I don't hear any adventitious sounds such as stridor or wheezing, which would be abnormal. Her appearance is within a normal limit. Her rate seems to be regular, about a 16 breaths per minute. Usual finding would be like 12 to 20, so that's well within the normal range. I can also, I will go ahead now and check for diaphragmatic excursion here. Palpate her 10th rib. If you would go ahead and take a deep breath for me. Breathe out. One more time. All right, go ahead and breathe out. All right, very good. My hands, her chest wall was moving symmetrically and equally on each side, which is a normal finding. I will go ahead, also I would palpate for crepitus. I don't feel any, it would sound like a crackling noise. It's air stuck in the subcu tissue, which would be an abnormal finding. I will now check for tactile fremitus. So whenever you feel my hands on your body, or on your back, if you would go ahead and say 99.
99.
Okay.
99.
Okay.
99.
Okay.
99.
Okay.
99.
Very good.
99. 99. 99. 99. 99.
Very good. All of that sounded dull in all areas, which would be a normal finding. I will go ahead and percuss her back and check for resonance. Okay. Anteriorly. If you would go ahead and lift your arms up for me, laterally as well. Very good. Go ahead and rest your arms down. So the pitch was low, the duration was long, the quality was hollow, and the intensity was dull. Those are all normal findings within the normal limits. I will now check for diaphragmatic excursions. If you would just go ahead and take a deep breath in for me and hold it. I'm just trying to percuss for an area of dullness. Okay. Breathe out. Breathe in again and hold it. Okay. Go ahead and let it out. The difference between those two sites seems to be about 3.5 centimeters, which is a normal finding. Normal findings would be anywhere from 3 to 5 centimeters, so like I said, that is within a normal range. Now I will just go ahead and auscultate all of her breath fields. Go ahead and take a deep breath for me. Very good. So posteriorly, I can hear broncho and vesicular breath sounds in her upper lobes and vesicular sounds in her lower lobes. They sound clear, no adventitious sounds. That's all normal. Listen anteriorly. Once again, I heard vesicular breath sounds in all fields, which is normal. They sounded clear. No diminished fields or coarseness, no extra adventitious sounds at all. That is all normal. I will now check for vocal resonance. When you feel the stethoscope, if you would go ahead and just say the word 99.
99.
Very good.
99. 99. 99. 99. 99. 99. 99. 99. 99.
Very good. Whenever she was saying 99, it sounded dull, which was within a normal limit. Now that concludes the portion of the pulmonary assessment. If we could move into the cardiac assessment. I'm going to start again just by inspection. I don't notice any JVD in either side of her neck. There's no cyanosis, no superficial veins. If you would go ahead and lay back for me, I will palpate the precordium into the left sternal border, the base into the right sternal border, and then I will palpate your apical pulse. Feel your carotid pulse at the same time. They are synchronous, which is a normal finding. I don't feel any thrills, heaves, or lifts. If you would go ahead and sit back up for me. I will now percuss the size of her heart. Typically, the best way to know the true size of a heart is by chest x-ray, but in case the equipment is not there, the way that you would do it is you would start percussing from the left. Feel for dullness. Come in through midclavicular line over here. Feel for dullness again. Okay. You would measure the size of those. Coming in from the right side, you typically wouldn't hear areas of dullness unless the size of the heart was outside of the right sternal border, which would be, or outside of the right side, which would make the heart was rather large and outside the normal limits. Feels as though her heart is within the normal limits. You would measure all 4 of those points, and that's how you would get an estimation of the size of the heart. And now if you would just go ahead and lean back again for me, I'll go ahead and listen to your heart sounds. We have aortic, pulmonic, tricuspid, and mitral. You would go ahead and lean on your left side and put your hand up. That's wonderful. Aortic, pulmonic, tricuspid, and mitral. Alright, and then last position, if I could just have you sit up and then lean slightly forward. Aortic, pulmonic, tricuspid, mitral. Okay, I heard S1 and S2. I didn't hear any additional sounds such as S3 or S4. Her rate was regular. It was, there weren't any murmurs or clicks or anything like that. No muffled heart sounds. Everything sounded clear. And that concludes my cardiac assessment video. Thank you so much.